A very good evening to one and all. This year, Sattva Charitable Sanstha will be completing 10 years service to humanity. I, Dr. Yarish, welcome you all to the fifth live webinar organized by Sattva Charitable Sanstha. It is a saying, a way to a man's heart is through his stomach, but in reality, a way to any person's diseased heart is through their oral cavity. A record breaking number of diseases originate in our oral cavity, from a simple streptococcus infection to deadly diseases like Ludwig's angina and infective endocarditis. Today, we have with us a dynamic personality in the field of dentistry. It is my honor to invite my colleague, Dr. Nithya Ramesh. Dr. Nithya has secured first rank in final year BDS and subject topper in public health dentistry and pediatric and preventive dentistry. She has presented papers in Conexon 2020, IDC 2020, WDS Udan 2022. She has secured third prize at Conexon 2022. She has been an inspiration to all youngsters, and to add to her laurels, she is a voracious reader and writer. She has published in the Writer's Orders How to Save a Mockingbird, published in the Writer's Pockets, Dreamcatcher, Stand Still, and Importance of Mental Health. Kindly note that doubts will be answered after the session. Any queries can be written in the chat box. I request Dr. Nithya to kindly proceed with the session.
Hi, thanks Yarish for such a nice and sweet introduction. Okay, I'm gonna share my screen. Just give me a second. Hi, can everyone see my screen? Okay, thank you. Okay, so basically, the oral cavity, like you said, Yarish, it's a home to millions of diseases and infections of all kinds. But in this session, we're just going to take a tiny peek, a glimpse, if you will, to just understand what all we can see. Just a fraction of the diseases in its description. So first, I would like to begin by explaining what exactly the oral cavity is all about. So we all technically know what it is. It's home to the teeth, to the gingiva, to your lips, to the tongue, to your floor of the mouth, to the hard palate, the soft palate, everything. We've read this in anatomy. We know its definition in theory, but what is it? It's a literal domain of its own. It doesn't just start as a single problem. It's like 15 different things all inside this one small area of maybe 45 mm. And inside that, there's this whole world of like tissues that we have. We have hard tissues and soft tissues alike, and we see everything. Through this, I just want to kind of orient you with exactly how the oral cavity is. So we have the teeth and we have the gingiva over it. And basically that is the primary focus of this webinar. We will also be covering a few conditions that we can see in other areas of the mouth, but most of our problems begin with the teeth. Okay, so these are basically the contents that I would like to cover through this session. And we will start off really simple with what exactly is the tooth and what is the gingiva. Now, we all know what the tooth is in theory. We have the crown, like, a king sitting right on top, what we see in the oral cavity when we open our mouth, the crowns of various different teeth. We have the necks of the teeth, which is just a small area which just lies near the gums. And we have the roots. So going into, if I had to take a longitudinal cross section, if you will, I'll kind of explain to you what exactly you see. So you have your enamel layer right on top. That is just in your crown section. And just like you have the enamel, you have the cementum in the root section, just around the outside of the tooth. Then you have the dentinal layer, which extends from the crown right up to the roots, all the way to the bottom of the tooth. And you have your pulp right in the center. So you have your pulp cavity, which is a major chunk of the pulp. That's like the main section, which you see in the crown area. And then you have your root canals, which go right up to the apex. And you have a rich supply of nerves and blood vessels coming in from the pulp chamber. Um, Basically, besides your tooth itself, you have the gingiva. So this pink thing that we see over here is the gingiva, which surrounds the tooth and kind of holds it in place. But between your gums and your root surface, there are these fibers that kind of bind it and hold it down. That's what we call the periodontal ligament. It is a very, very important chunk, which we often ignore and we often don't know about, but it's a very significant part. It's right between the root and the root surface and the gums itself. And we have the alveolar bone, which is basically a supporting structure without which the tooth wouldn't stay in place. Now I'd like to begin with the examination. Now, as we all know, patients come into the clinic and the oral cavity often gets neglected. In my profession, not so much because, well, it's all about the oral cavity, but it often does. The first thing that you do in the examination is you tell the patient to not be scared because most patients come in with this fear of the dentist or the dental chair itself. You make the patient sit and you switch on this light. The light is basically a boom because without it, I don't think anything would be visible. So we switch on the light and we have these major tools that are there in almost every clinical setup. Without these tools, examination of the oral cavity is almost near impossible because we really, really need them. So to begin with, I'd like to talk about the mouth mirror. The mouth mirror itself is this tiny little mirror, which maybe would be around, say, 2 to 3 centimeters. And it kind of gives you a view into the oral cavity. It doesn't just play the role of showing what the teeth, their positions, what conditions they have or anything. It also reflects the other tissues. So you get better access into the oral cavity. Then we have the probe. Now, the probe is basically one of the most important diagnostic tools that we have. And it's actually very, very, very important. Basically, what is happening is, for example, if there is a tooth, and if we see that, yes, there is probably a condition or anything that might be present, I'll come to this more in detail. But I'd just like to explain it to you in a gist here. So the probe, basically, we call it walking the probe. So quite literally, like, a human being walking on the road, the probe is literally run across the grooves that are present on the tooth surface. Now, we don't call these grooves. We call them fissures. You would have seen these crawly lines along on the tooth. We call them fissures and pits. So the probe literally walks along the fissures. We take the probe and we walk it along the fissures. And there will be places where the probe itself gets stuck and it doesn't move forward. We call that a catch. That itself indicates caries. I'll explain this more in detail when we go forward. The next tool I'd like to talk about is the Explorer. Explorer has two ends. One is this end, which is what we call the sickle-shaped end, which, much like the probe, also helps in analyzing the caries presence, the conditions on the tooth surface, and also it examines the gums. So you can run it along the gum level and you can understand if there's any condition over there. You can also gauge the presence of plaque and calculus. Again, I'll come to this more in detail later. And we have the tweezer. The tweezer basically, so sometimes the patient comes, most often the patients come with the complaint of pain. And a person will be saying, oh my God, my tooth is really hurting. I don't know what I'm going to do now. But the most important thing is we can't really understand what's wrong with the tooth just by looking at it. You kind of need to analyze the health of the tooth inside. So, like I said, you can see if there's destruction in the enamel or the dentine. That's kind of clinically visible to you. You will be able to see it. I'll show you pictures later. But the tweezer will help you get a quick diagnosis if at all the pulp is involved. So, as infection goes down into the tooth, the tweezer comes into play. I'll explain this to you all later. And we have the pulp tester. The pulp tester also will come in later. These two play a role in helping us diagnose if the patient has this condition called pulpitis, or more commonly called pulpal inflammation. And I'll tell you about it in a bit. Next, I'd like to talk about radiographs. Now, I think dentistry basically starts off with a very simple process. We check clinically and then we try to analyze if the patient has a condition or doesn't. But nothing can be done. No step, no treatment can be done for the patient without a radiograph. The radiograph is the single most important tool in dentistry. It is literally the Bible. We will always take a radiograph in every case. There are various kinds of radiographs that are used. There's intraoral, there's extraoral, there are so many different lesions that you can see on radiographs. And to think a simple X-ray is all you need. But in our profession, what I have seen is the radiographs play the most important role in the diagnosis of any condition. And it's very, very important to learn how to take the radiograph properly, and not just to learn how to take it. It's more important to learn to understand what you see in it. Because there are conditions that are present in radiographs that more often than not get missed. But through a radiograph, we can understand what level the disease is at. Maybe not 100% accurately, but you can understand it to a great extent. So I'd like to tell you some advantages of taking a radiograph. Now, what you can see in the oral cavity is this tiny portion of the crown, right? That's all you can see. But there's this huge root below it. And there is the gum, and there's the area below the root, as in the bone itself. We can't really see this clinically, can we? So that's the purpose of taking a radiograph, because bone is a hard tissue. Enamel, dentine, cementum, everything, all of these are hard tissues. So through a radiograph, we can understand if the infection itself has reached the bone level. And when it reaches the bone level, what's going to happen is a slow decalcification and the presence of an infection. So if I were to tell you, so extraoral radiographs are not going to help us much in diagnosing an intraoral condition. But the different kinds of intraoral radiographs that we have, that we use very often are, the first is the intraoral periapical, then there's the bite-wing view and the occlusal view. So the intraoral periapical is by far the most commonly used radiograph. We call it the IOPA because intraoral periapical. So basically what is done is a film, maybe around, say, 3 centimeters in size, a tiny little film, is just placed in the inside of the mouth near the tooth of complaint, and we shoot the radiograph. The radiograph is developed and we can see these different kind of findings. These are all different intraoral periapical radiographs that I gathered for you all. If you focus on this radiograph, you can see a very distinct lesion over here. Similarly, in these, you can see lesions as well as restorations. I will come to this in a bit, the caries appearance on radiographs. The bite-wing and the occlusal radiograph are used more commonly. Like, for instance, the bite-wing radiograph is used when you need to take a set of 4 teeth. Why would you take 4 different IOPs? You can just take one bite-wing and you can get a view of one section of teeth on one side of the mouth. And the occlusal view is used to analyze all of the teeth in one arch, as in either the entire maxillary section or the entire mandibular section. The most important extraoral radiograph that we have is the OPG, orthopantomogram. So this radiograph gives you an assessment of all the teeth present in the oral cavity, the ones which have erupted and the ones which are hidden away in the bone, because very often we do have those, don't we? So this basically helps you see all of that, as well as a little bit of the bone structure, the sinuses, sometimes the TMJ joint as well. So the orthopantomogram is used when you have too many radiographs to take, and it also gives you a very good analysis of the bones that are there. Next, we're going to start with the diseases of the tooth. So here is a healthy tooth, and this is a very, very, very grossly destructed one. So the first and most common disease that we do see is dental caries. There is nothing more common than dental caries in this world. It is the single most common non-communicable disease worldwide today. Almost every person has at least one carious tooth in a very initial stage. Now, we all know microbiology. We've all studied it. We've all seen the different microbes that we have. But the bacteria that plays the most important role in dental caries is Streptococcus mutans. It lives in our oral cavity, normally, because germs like that. But Streptococcus mutans doesn't just exist in the oral cavity. It has a best friend. and that best friend is sucrose. So how this process works in a gist is, say I'm a person who has a lot of sweet food, and I do. I'll pick up something sweet, say a jalebi, and I eat it. There's a little bit of sucrose. The presence of sugar is very high in anything like jalebi, for instance. It's really high. There is going to be a little bit of sugar stuck in the mouth for a period of time. And now, obviously, I've had the jalebi. I've not brushed for a while. I'm not going to brush every single time of the day. So this sugar stays back in the mouth. The sucrose stays back. And Streptococcus mutans loves sucrose. So it will slowly break it down. And while it's breaking it down, it will bind to the tooth surface and it'll break down the tooth. So what's going to happen is using the sucrose, the Streptococcus mutans gets enough ATP, breaks down the tooth surface itself, and leaches out these acids, which continue the destruction. So what initially appears as, a normal process, you're just eating food, is going to end up causing a severe destruction of the tooth. So like I mentioned earlier, you take the probe that we spoke about during the examination phase, you walk it along the fissures. This is the tooth, and you see these fissures that are running across in cross section, right? So you're walking the probe across it very gently, and you'll realize that in one place, say in the center, right there, it's going to get stuck. That the fact that it gets stuck over there is the presence of dental caries on that tooth surface. So there are very different appearances to caries. Initially, you will not be able to see it. It's a white lesion which will appear only when air dried. But slowly, the presence of discoloration takes place. If you notice on this tooth right in the corner, you can see a discoloration and there is a slight carious appearance, but you can't make out how extensive it is. The lesions in the oral cavity are always, and they have this iceberg effect. Like the Titanic, what they could see was this tiny little thing popping out of water, and what inside is a massive iceberg that destroyed an entire ship. That's basically what's happening here too. So here, I have this picture here, as you can see. Right on the top, you have this tiny little lesion, and that's all you can see. A small little presence on the tooth surface. But deep down, all of this is destroyed. Everything here is caries. So what you're seeing clinically is one tiny little dot. And as you go inside, there's a huge cavity built. That's what happens. The word cavity is basically the presence of a hole in a tooth. A cavity literally means a hole. That's what dental caries causes. When people say I have a cavity, they mean they have a hole in the tooth. But the cavity is the presence of dental caries on the tooth. So there are three different clinical appearances in dental caries that we see. Actually, there are many, but these are the three types of caries that are the most invasive, if you will. So first is pit and fissure caries. So you've got your pits, you've got your fissures, which are the lines, the scrawly lines that we see running along on the tooth surface, on the crown, when we literally look into the mouth or in the mirror. So the presence of caries in these small little lines running along the tooth surface, that is your pit and fissure caries. All these, the place where two fissures meet would be a pit, and the lines across are the fissures. So the presence of caries in those areas is basically what pit and fissure caries is all about. Smooth surface caries. Now, smooth surface caries is a less encountered caries, but it is seen very often and it is very often neglected. So a healthy tooth looks something like this, right? Like, I'll just go back and show you. Yeah, this is a healthy tooth. But you see these areas along the sides of the tooth. These areas are the parts. Basically, they are the surfaces around the tooth, as in on the different surfaces. When caries invades into these surfaces, the appearance is a little different. In pit and fissure caries, what is happening is you have a triangle. Imagine a triangle. The apex of the triangle is towards the outer surface, and the base of the triangle is towards the place where the dentine is beginning. In smooth surface caries, it's the base of the triangle that you see outside. So as you can see over here, the lesion outside is bigger whereas as compared to the lesion on the inside of the tooth. So this is a reverse type of caries, but it is also very, very aggressive in nature. Next, I'd like to come to root caries. Root caries is seen mostly in older people. So the thing about root caries is when the root is exposed to the oral cavity, a different set of bacteria come into play and cause this type of caries. It's not encountered very often, but when it is very, very aggressive and it causes tooth loss very, very seriously because If the root gets destroyed, you're losing the very support of the tooth, the home of the tooth. There is nothing to hold it back. It's just going to start decaying and it'll keep spreading. Because once this process starts of root caries, it's very hard to stop. Okay. So that basically explains your caries part. But the next condition that we need to come to is the pulp. So in this diagram, if you see very carefully, we have reached the pulp. It's gone right up to the pulp chamber, like I explained to you right at the start, the pulp cavity. So what is pulpitis? Pulpitis literally means the inflammation of the pulp, right? We all know itis means inflammation. So inflammation of the pulp, very literally, is pulpitis. What is happening is your enamel and your dentine are both destroyed by caries and the infection has reached the pulpal chamber. Now, if you see this diagram that I've put here very carefully, you can see that the enamel is infected, the dentine is infected, and the lesion has reached the pulp. The pulp is red in color. What is the first thing that happens in inflammation? Redness. We know those 5 cardinal signs of inflammation. It's the same thing in a tooth as well. So you have your rubor coming in. It's getting red. You have your increase in size that's taking place. All of this is going to happen. Basically, the hyperemic change. Now, pulpitis is a complaint that involves pain. So the patient comes. Now, like I mentioned earlier, I have a thing for sweets, right? So a patient has come into my clinic, for instance, and the patient has eaten a lot of ice cream. My patient says that I have a lot of pain, doctor, but only when I eat ice cream. When I eat ice cream, the pain is a lot. And when I don't eat ice cream, the pain is very less. It's almost non-existent. So I'm fine when there's no ice cream. But when I'm eating the ice cream, there's a lot of pain. This is what the patient is telling me. Now I'm going to tell you something. There are 2 types of pulpitis. There's reversible and irreversible. Now the patient is saying that the pain that he's feeling disappears when he stops eating ice cream. That is what reversible pulpitis is. The stimulus, the presence of an addition to the tooth, if you will, an external force on the tooth, is the ice cream here that I spoke about. So basically what is happening is ice cream is playing the role of a stimulus. When it's coming in contact with the tooth surface, there is this change that is causing severe pain. And the patient is saying, ouch, it's hurting so much, I can't eat ice cream. The minute the ice cream is gone from the mouth, the pain is gone. Because the pain was literally caused by the stimulus. The stimulus is coming, acting on the tooth, causing a reversible inflammation, a hyperemia, which settles on its own on removing that stimulus. So reversible pulpitis is very easy to treat. As long as the caries condition is removed, normally the reversible pulpitis does settle. So there is no chance of an infection actually having grossly disrupted the pulp. The pulp is more or less intact. It's just because the lesion is very close, because there's slight invasion of microbes, that there is this inflammation that is coming and going on its own. So it's just this presence of a stimulus which is acting as a force to cause the pain. In irreversible pulpitis, the same patient who earlier complained that the ice cream, only the presence of the ice cream was causing the pain, now will say that the pain is persistent throughout. As in, he eats the ice cream, it's there. He doesn't eat the ice cream, it's still there. The pain is non-stop, it's sharp, it's shooting, it's causing him so much of pain that he's not able to function as a person. Now, this is when intervention becomes very important. What is happening in irreversible pulpitis is the condition cannot be reversed, very literally, as the name suggests, irreversible. Here, the pulp is so inflamed that the presence or absence of the stimulus does not determine the extent of the condition that the patient is in. The patient's pulp is infected invariably. So this has 2 types. Irreversible pulpitis can be acute or chronic. In acute, the pain is present. It's sharp, it's shooting, it's there, even on removal of the stimulus. But a chronic condition, as we all know, is something which has existed for a long period of time. Acute is very momentary. Chronic is something that lasts for a long time. So the infection is just staying and persisting. So by the end, the patient barely has any pain left. He would have ignored the pain when it's there, or would have taken a painkiller and just been like, it's okay, it's just a mouth condition, it'll be fine. But that's not what's happening. The infection is continuing and is destroying the pulp. That is chronic irreversible pulpitis. Barely any pain, but the whole pulp is inflamed. But the infection is confined to the pulp. It's not gone beyond. So the treatment of this normally goes on to become your root canal treatment because invariably there are very few options. To talk about the pathology in a very simple way of what's happening in pulpitis is, like I said, the tooth decay, the enamel, dentine, everything is getting affected. And the mitochondria, the same, our very good friends, Streptococcus mutans, just continues injuring and then it enters your pulp. And now the infection goes down, infects the whole pulp. This is quite literally a relatively healthy pulp. And the yellow that we see on the right side, that is the infected pulp. And the inflammatory response is quite similar to the inflammatory response in any part of the body. You have your plasma cells, your macrophages, and an increase in general of your fibroblasts and everything. It's your typical inflammatory response that you're seeing. An invasion of neutrophils. You've got different zones. That is what it's very similar to every other thing. But this is how pulpitis goes. Root canal treatment, like I mentioned earlier, is the only treatment for irreversible pulpitis most of the times. So this is your caries and this is your infected pulp. What you're going to do is you're going to clean out all of the decayed tooth material. You're going to remove all of the carious material and you're going to basically remove the pulp as well because it's infected. You don't want to keep it there because if you keep it there, it's going to continue spreading its infection all around. So you're removing all of the infected pulp. We have these different instruments called files. They basically help in going into the root because we can't exactly scoop out in a root, can we? So we're scooping out all the pulp from the cavity itself, the pulp chamber on top and the crown. And we use these files to clean out the pulp which is present in the root and remove all the infected pulp from the tooth, fill it up with healthy material called katapocha, sometimes using posts, and restore the tooth back to its healthy state, put a crown in some cases, and the patient is back to normal. The patient will have no pain after this. So root canal treatment is your first and foremost step when a patient presents with pulpitis, irreversible pulpitis. So basically, pulpitis is not the last thing that you see. It goes further. Like I said, there is your enamel caries, there's dentine caries, all of this has gotten infected over here. You can see the inflammation of the pulp. But then there is something else that happens. The inflammation, in some cases, continues and it reaches the alveolar bone. Now what is happening is, this is your root. This is the apex of the root. The infections pass through that and it's entered the bone and it's destroyed the area over there. And it's caused an abscess. We've all seen different kinds of abscesses in clinical states. But this is something which is called a periapical abscess. It's a slightly different condition. And a stage before the periapical abscess is what we refer to as apical periodontitis. It's easy to confuse periodontitis with a gum condition, but apical periodontitis, apical, the name itself, is a caries condition. It's a part of the progressive caries condition. So periapical disease is basically when the infection has left the pulp, and not left the pulp, it's present in the pulp and it's gone to the alveolar bone and caused an infection over there. So there are basically 5 major conditions. There are actually millions, but I've chosen to cover 5 because it will help you understand the main different types of conditions that you can see. So first, what is happening is we have the periodontal ligament. Remember when I spoke about it right at the start? It's what holds the tooth and the gum together tightly. So basically what is happening is the infection is leaving your root apex and it's just entering that ligament and destroying all the fibers over there. That is apical periodontitis. So as you can see in this X-ray, these are all IOPAs. You can see this infection is just around the root. Just slight widening of the root, that is apical periodontitis. Now, if this patient leaves this as it is, I'm fine, thoda sa pain hota hai, dull hai, theek hai yaar, main manage kar lunga. The patient does this, and they do. Most patients do this. The infection is going to go and cause decalcification in all the bone around. Now, basically, it's destroying the bone. So then it's going to start looking like this, a haphazard destruction of the bone just below the root. That is your apical abscess, periapical abscess. You have 2 types. You have acute and chronic, just like everything else. Acute abscess will present with the patient having pain and everything is hurting. And chronic abscess is when the patient has a sinus tract which is draining and you'll see pus in the mouth and swelling and everything. So abscess is a very bad condition. patients should not let it reach this point. And as a clinician, we should be able to diagnose it when it's in the apical periodontitis stage, if at all it has progressed to periapical disease itself. So okay, let me continue. Chronic apical periodontitis is basically what is happening is the infection has started sort of resolving. You have kind of sort of given painkillers to the patients, antibiotics to the patients. So what is happening is the infection is slowly reducing. So there is granulation tissue which is present at the apex of the tooth, and it's very small. So this normally with just a root canal treatment can get resolved. In abscess, sometimes you need to do an incision and drainage in some cases, depending on the extent. Periapical cyst. Now, this condition is basically a very, very large spread of the infection all around the root. It's going to have a very distinct border when you see it on a radiograph, and there will be a swelling. And when you do, your drainage and everything, you will get like fluid which will be slightly reddish brown in color, sometimes yellowish in color. It depends. There are many different types of cysts. But cysts in general normally require many, many more interventions. Like it's not going to resolve with just a simple root canal treatment. You may need to do a mini surgery to get the entire cyst extended out because it has this epithelial lining. And then we have condensing osteitis. In condensing osteitis, what is happening is, like I said earlier, there's a destruction of the bone. But these osteoblasts, as we know, like they are already present. They start forming new bone again. So there is a layer of destroyed bone, and then there is a layer of newly formed but overly calcified bone, which is what we call as condensing osteitis. It is not your regular bone. It is sort of bone just to replace, but it doesn't replace. It just causes one more lesion over there, which needs to be removed because that bone is not healthy bone. That bone is just diseased bone, which is just getting formed because the infection is spread so much. So all of this is how you radiographically distinguish between different periapical diseases. But if I had to clinically figure out if the patient has a periapical disease, the easiest and most common tool that we use is something called the POP test, that is pain on percussion. So what you're doing is you have your mouth mirror, you have your probe. All of these I described have a handle as well, right? A relatively long handle. You turn the instrument in your hand and you hit the tooth vertically along the long axis, as in if this is the tooth in the mouth, you're going exactly like this. And you're going to hit it a few times, very gently. You don't want the patient to yell at you. Very gently, you're just hitting the tooth a few times, and the patient will feel pain. When the patient complains of pain, the reaction will look something like this. That increase in pain, when you're just hitting the tooth vertically, is what is called POP positive. As in, there is pain on percussion, which means that the patient has a periapical disease. Now, it's important to know that I mentioned the term vertical as in along the long axis of the tooth. Only then will the patient have pain. That is important to understand in the diagnosis of periapical disease. Okay, that about covers almost all of the diseases of the tooth. It doesn't, but it's a gist of the major conditions that we see. So next, we leave the tooth and we come to its best friend, the gums. So the gums basically have two conditions that I would really like to speak about. One is gingivitis and one is chronic periodontitis. These are basically the same disease that's progressing. So this happy dude is a healthy tooth in the gum, and he's getting a little bit upset because the gum is getting slightly inflamed. Now I'll just go into gingivitis and explain that part to you. So gum disease or gingivitis. Now, many times the patient will not come with the complaint of pain or anything in his teeth. He won't say sadan hai ya dard ho raha hai. No, none of that is a complaint. Sometimes the patient comes with a complaint saying that मुझे दांत की सफाई करना है, बहुत दिख रहा है, बहुत अजीब दिख रहा है, मुझे अच्छा नहीं लग रहा है. In these cases, the patient's complaint is in an entirely different zone. That means he wants the teeth to become clean. Now, all he's thinking is the teeth need to become clean. He can see food particles and all stuck to his teeth. So this patient has come to you and he says, I want cleaning. You ask him to open his mouth. You do your examination, your routine check, and you see that the patient has the presence of large, thick bands of calculus. Now, I'll just tell you a little bit about what is plaque and what is calculus. Plaque is like a collection of debris and microorganisms that is just stuck to the tooth surface that can easily be removed. but they're not exactly visible to us. Calculus is a calcified version of the same plaque, which is clinically visible to us. You will see yellowish bands present around the gums. That is calculus, most commonly seen in the back of your lower incisors. Your four incisor teeth here, right behind them, you'll see these bands which are seen. In many patients, that is the first place it gets deposited. So that is the presence of calculus. Now, not to scare you or anything, but it is very often said that gingivitis is a condition which is seen in every human being. Every person is in a state of gingivitis except when they've just come from a treatment. It's often said this. Why? So every person eats food. Every person has, a little bit of plaque and calculus present, because as much as you brush, you are the best person at brushing, you got an award, there is still going to be a little bit of something left behind. That, with our normal bacteria that live in our mouth, will have a reaction, and there'll be the deposition of a little bit of calculus, and there is always a slight state of inflammation in the gingiva. But let's talk about the more serious type of gingivitis that patients present with. Now, a patient comes to you, मेरे मसूड़े से खून निकलता है. Now, you hear this and you're not supposed to get intimidated. You're supposed to know, okay, this patient probably has a history of a condition in the mouth. There is something wrong with his mouth. Let's check. Now, the patient opens his mouth and you're seeing that the gums itself, they don't look very good to you. If you see this picture, your lower gums here are more or less fine. But if you see the upper gums, now you know that's not normal because there's blood along these teeth. As you can see, there's blood along these teeth. Next, what you can see here is the presence of swollen gums. Can you see these papilla, these sections between the teeth? They look slightly inflamed. They don't look very healthy. That is pulpite. That is gingivitis. Now, this inflammation that you see around the gums is gingivitis. The next thing that you can see here is a swelling. It's like slightly swollen. It's lost its normal appearance and it looks slightly shiny. Gums in general are not supposed to look shiny on a normal day. It's supposed to look more like smooth, firm, resilient. This looks slightly flabby. So the cardinal signs of gingivitis are bleeding on probing. What is bleeding on probing? You take this little probe in your hand, our probe, our best friend from the start. You run that little probe right along the gums. You're not supposed to go inside and pierce the gum. It's just going along the tooth, very gently, just shifting the gum along the tooth. If you do that and the patient starts bleeding from there, you know the patient has gingivitis. That little bit of blood that comes, that's gingivitis. The next thing you'll see is redness. You'll see edema. There are a lot of other things you also see, like loss of stippling. But stippling is basically there's this orange peel appearance of our gums. Most of the times you don't see it, but if you take a cotton pellet in your hand and you just wipe one section of gums and you focus it under light really well, you'll be able to see these tiny, 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 tiny dots running along the gum. That is the presence of stippling. When it disappears, that is loss of stippling, and that is a sign of gingivitis, a more serious stage of gingivitis. Now, the bacteria that come into play here. So the most often seen is AA, Actinomycetum comitans. This and Porphyromonas gingivalis. These are the two most common bacteria that are seen, and we call them the red complex bacteria to just simplify life. The treatment of gingivitis is relatively simple. You do your scaling, which is a basic cleaning of the mouth using an instrument that we call a scaler, a universal scaler. So we do this cleaning of the mouth. We give the patient mouthwashes. We tell the patient to clean their mouth regularly, do 6 months checkups and everything. And normally the inflammation reduces because the calculus and everything has gone away. Next, we come to this thing called periodontitis. Now, gum disease, if left unchecked for a very, very long period of time, will eventually go on to destroy the very fibers that hold the tooth to the gum. What's happening is, at one point in time, our gum was here, our tooth was here, everything was normal. But the infection has come on the gum. Now it's going to start going and making your gums start getting weak. So it will start pulling your gums down. It will start breaking the fibers that are holding the tooth to the gum. All of that is going, and this gum itself starts moving downwards. That stage, when the gum starts moving down from the tooth, is chronic periodontitis. Chronic periodontitis is a very severe form of gingivitis, a very, very severe form, and it's given a separate name for that reason. Chronic periodontitis should not be confused with apical periodontitis. Apical, like I said, is an infection of the tooth that has gone further. Chronic periodontitis is an infection of the gums. So what's happening here? Here your cardinal signs are a little bit different. Your tooth and gums which were married have now gotten separated. So you have recession, as in there is a loss of attachment and the gum has moved down. The gum has shifted from the crown, where it was happy, to the root. So you have the exposure of all of these roots. Can you see this is very clearly evident in all these pictures that the root surface is exposed. That is recession. There is a loss of attachment, obviously, because they were in contact and now they've separated and moved down. The presence of periodontal pockets. What are pockets? Pockets are like a deep sulcus. Basically, the gingiva and the tooth are at this angle. So this area is a sulcus. Now, when the sulcus starts looking something like this, more deeper, this is still your tooth, but you have the gum going like this, that is a deeper sulcus. As in, there's an inflammation which has caused the sulcus to move down, but the gum is still at the same level. When it starts appearing that way, you have the presence of pockets. In this picture, I'm not going to be able to show you, but if you can see, this gum over here is slightly reddish, and it's still at a relatively okay height. But this inside would have a periodontal pocket. The next thing that you see is mobility. Mobility is basically the teeth getting mobile. So how will you check if the patient has mobility? You take two instruments in your hand, say the mirror and the probe, but you take the backside of these two instruments. The same one which we used for the POP test, you take that and you hold the tooth and you try to shift it. As you try to shift it, if the tooth starts moving, that's a mobile tooth. And the next cardinal sign that you see is bone loss. So bone loss you can only see in a radiograph, like I told you all right at the start. So if you look at this OPG that we have down here, the bone level in the maxillary teeth has moved. Here, this is the bone height. Your normal bone height should be, as you saw in the first OPG, very high. But in this, all of the bones have gone down. This patient is in a state of chronic periodontitis. And this requires treatment, which is way more serious. So I don't know if you know this, but diabetes has 6 complications according to the society. So you have 5 things that are systemic conditions. But your 6th complication of diabetes is chronic periodontitis. So whenever a patient presents with diabetes to the clinic, it is very, very important to check the oral cavity because more often than not, there is chronic periodontitis which is going unchecked. So since all of you are going to become diagnosticians very soon, all of you all will be doctors, it's very important for you all to do this one, take a minute, ask the patient to open their oral cavity and check because the patient will probably have gingivitis at least, if not chronic periodontitis. And by asking the patient to get treatment done as soon as possible, you are helping at least the oral cavity. Okay. So how do you treat chronic periodontitis? You have your scaling and cleaning. You're basically cleaning all of the teeth. You're doing all of that again. But since these teeth may sometimes move or be mobile, you will ask the patient to wear the splint, not wear. You will fix the splint itself. So you're splinting the teeth together, holding it in place. And sometimes when the condition is very, very serious, you may need to do flap surgeries, bone surgeries, just so you can, bring back the tooth to a place where it can sustain. The next thing I'd like to talk about is how exactly this is progressing. This is your healthy gums and tooth. You have the presence of plaque around the surface. So mainly the plaque will get deposited around the gums, like I mentioned earlier. So you have this plaque coming and sitting over here, calculus coming and sitting, and this is causing an inflammation. This is your gingivitis. This redness that you see in the gums just over here, that's gingivitis. Now here, can you see this? This area is getting deep. It's forming a little socket. So we call this a periodontal pocket here. And this bone over here itself is getting destroyed. This is a state of chronic periodontitis. But a more severe state of chronic periodontitis will look like this. A pocket which is so deep that food lodgement will start happening. The whole root itself is exposed here. There is bone loss to such an extent. Now this tooth will probably be mobile. It will be shaking in the mouth and it will cause the tooth itself to fall out. Sometimes the patient will just say, "Mera daant nikal gaya, haath mein hi aa gaya." And you'll see the whole tooth is there and the gum itself has gone down. There's nothing to hold the tooth. Okay? Now, that is the relationship that you see in the tooth and the gums. But there are more things. There are oral lesions itself. So we all know that smoking, eating tobacco is very, 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 very bad. We've seen the movies, we've seen the ads that come for 15 minutes right at the start. Please don't smoke, please don't eat tobacco. We know what it looks like. But do we know more about the precancerous lesions and oral cancer itself? So I'm going to tell you a little bit about this. Smoking is very bad. Eating tobacco is worse. And more often than not, a patient who presents with a history of eating tobacco or smoking, it's important to check the oral cavity because there will be findings. There will be stains on the tooth itself, which you can see. More than that, you will see lesions. Now, I'll explain to you how exactly you can see them. You ask the patient to open his mouth. And there are these things called precancerous lesions and conditions. So what you're going to see is patient open the mouth and there's this huge white patch sitting on your cheek. And you're seeing the patch and you know that there is something wrong here because our cheeks on the inside look pink, right? But suddenly you're seeing there's this huge white patch that's stretching at the back. Here, this patient has the white patch on the bottom of his tongue, but he doesn't know he has it. So you open the mouth and you see this. Okay, this patient looks like they have a condition here. This doesn't look okay. This is what we call leukoplakia. Leukoplakia itself is a white lesion that is seen in the oral cavity, which when you try to remove it, try to peel it off or try to scrape it, it's not going to come off. So it's a non-scrapable white lesion of the oral cavity, which cannot be put in as any other lesion. That is leukoplakia. And it's one of the most severe conditions. All three of these that I've put here, leukoplakia, oral submucous fibrosis, and lichen planus, all three of them have a very high tendency to turn into oral cancer, with leukoplakia being at the most. Many, many cases of leukoplakia will head on to become squamous cell carcinoma, which is cancer of the oral cavity, most common cancer of the oral cavity. The next thing I'd like to talk about is oral submucous fibrosis. Now, patients will say, "मैं betel nut चबाता हूँ." Correct? We've all heard it. So what's happening is betel nut has a few acids. They're getting leached into the mouth and they are causing a reaction. They get transformed into a chemical which causes an increases in fibrosis, as in there are presence of there's a fibrotic change that is happening. So what's happening is our mouth is soft, right? In general, when you touch your cheeks, it's all soft. But in oral submucous fibrosis patients, what's happening is the whole cheek itself, right at the back, you will feel the presence of these bands. And the patient will say, "मैं मुंह नहीं खोल पा रहा हूँ, इतना ही खुलता है." And when you touch the back of the cheek, you'll feel it. You'll feel fibers. You'll feel hardness over there. And you know the patient is a patient of oral submucous fibrosis. It's another condition that is so serious that sometimes you need to give intra-lesional injections and still there is no resolution to the effect because it progresses. If the habit isn't stopped, these conditions cannot be reversed and they normally cannot be reversed. You just have to remove the lesion itself and hope and pray that it doesn't progress to become cancer. Lichen planus is a condition that you see in general on your skin as well, but it also has oral effects. You can see, your purple striae will be there in the mouth, and this also sometimes tends to become cancerous. The thing about lichen planus is you can still treat it. You can find some hope for the patient, but in advanced stages of leukoplakia and oral submucous fibrosis, normally there is no resolution and it progresses to cancer. Squamous cell carcinoma. This is the most common form of oral cancer that is seen. Now, we all know in theory what the different causes of cancer are. So you know that betel nut, smoking, having alcohol, everything can lead to oral cancer. Tooth decay itself can lead to oral cancer because the infection can persist. You know your UV light can lead to cancer. You know in theory what are the causes of cancer. But the thing is, patients are still unaware of these things. So our job as clinicians is to make them aware. When they come in and they say, "I'm smoking," stop the habit. "I'm drinking," stop the habit. We know the effects. So we should, as clinicians, tell them this. The next thing I'd like to talk about is the symptoms of oral cancer. So the first thing that you will see is a lesion in the mouth. The patient will say, "यहाँ कुछ अटका है, बहुत time से disturb हो रहा है मुझे, मैं खा नहीं पा रहा हूँ." So basically that is the presence of a tumor in his mouth. So because of the tumor, what all can happen? So the teeth can become mobile, loose. Sometimes they come out on their own. You will see red and white patches. You will see a tumor itself. The tongue will hurt. The patient will complain of pain everywhere. There'll be swelling. There'll be gross destruction in various areas. And you will also see mouth sores, small ulcers that will be seen everywhere. Now, where all can you see oral cancer? So it can be present everywhere in the mouth. Your gums, your upper gums, your lower gums. This is oral cancer of the lip, right here, a lesion. This is oral cancer of your palate, right at the back. You can see a lesion right up there. Oral cancer of the tongue, lateral border of the tongue. The lateral border of the tongue is the most common site of oral cancer, and you can see it on your cheeks. So coming to the lateral border of the tongue, can you see this lesion? Can you appreciate it? It's actually very, very extensive. And this very commonly will go down to the floor of the mouth, and it will cause an infection that will go on to invade your lymph nodes and everything along. So it is a tumor with a very, very high rate of metastasis. It's usually seen on the lateral border of the tongue. It frequently can involve lymph nodes and everything present. Like it'll go spread. It'll cause inflammation of the lymph nodes. And the treatment of squamous cell carcinoma would require an excision of the tumor, not just excising the tumor boundaries, but also excising 1 to 2 millimeters to centimeters of normal tissue, so that if at all there's any carcinomatous cell in those areas, carcinomatous changes present, you're excising that as well. So the chance of recurrence reduces. You would obviously need to give the patient a few runs of chemotherapy and radiotherapy so as to establish a complete, removal of the lesion itself. But squamous cell carcinoma tends to be really, really aggressive and requires extensive treatment, which lasts for more than 6 months. And more often than not, the surgery can cause removal of half of the structure itself, like half of the tongue, half of the floor of the mouth. It's very sad that patients don't know more about oral cancer, and we as clinicians should be more aware. So that brings me to the end of this session. These are my references. I used various textbooks that I've been following for my study. And I also used Google because it's basically a Bible. But yes, I used these textbooks. This is the end. Thank you. If anyone has any questions, now would be a good time. If you have any questions, you can put them in the chat box. Okay, what is the efficacy of the fluoride toothpastes available? Fluoride is very, very, very important. And after 3 months, what will be the effect? Okay, so firstly, no patient should be using a non-fluoride based toothpaste. Your tooth itself, your enamel structure, your dentine structure, everything is using, the structure itself is made of this chemical, a crystal, that is called calcium hydroxyapatite. This structure is very, very strong itself. Now what is happening is fluoride toothpastes, they leave behind these small little fluoride ions on the tooth surface. This fluoride ion will interact with the enamel, the dentine, and create a structure that is more reinforced. Now what is happening, like I mentioned earlier, Streptococcus mutans comes, attacks the tooth, everything. Your calcium is getting removed, and what's left behind is not strong enough to sustain. But if you're using a fluoride toothpaste, the fluoride will replace the calcium and bind to the hydroxyapatite crystals, forming a reinforced structure called fluorapatite. And that, when it's left on the tooth surface, is actually stronger than your calcium hydroxyapatite. So in essence, what is happening is a process of remineralization, creating a stronger and more reinforced tooth structure, which itself is a lot better. So the use of fluoride toothpaste is an absolute must for everybody. And if you're asking me what is the effect after 3 months, well, there will be no effect because fluoride's effect starts instantly. Within 2 days, your remineralization will occur. But will you see a clinical change in yourself when you open the mouth? No. But your tooth is getting stronger, which is why it's important to replace it with, to replace patients who come in saying, नहीं मैं दंत कत्ती use करता हूँ, मैं डाबर use करता हूँ with Colgate. Please use Colgate And don't just use a basic Colgate. Use a Colgate which has fluoride. Use Pepsodent which has fluoride. And Sensodyne, that is, as we know, it's given for sensitivity. That has more substances, the presence of fluoride is better. So yes, it is very important to use fluoride toothpaste. I hope that answers your question. What are the chances of developing skeletal or dental fluorosis? Okay, so not every person gets fluorosis. The first thing to understand is anything in excess, anything in limits is not good. There is a mean of the spectrum that we have to stick to. So patients who come from areas in Gujarat which have a lot of hard water, or Rajasthan which has a lot of hard water, what is happening is the ingestion of this extremely hard water and the presence of so much the quantity of fluoride which is way higher than normal, like 3.4 to 4.4 ppm. When that much water is going inside and that much of fluoride is going inside, that is when fluorosis will develop. So what's going to happen is you and I living in Mumbai, which has a relatively normal rate of fluoride in the water, are not going to develop fluorosis on a normal day. But a patient coming from those areas where the water itself contains so much of fluoride has a higher probability. And the probability of developing fluorosis occurs more at a younger age when the teeth itself are getting formed. In a later stage of life, yes, it can get developed, but it's more often when you're a child and you've grown up in those areas that you will have the destruction right at the start. And a person with fluorosis will appear with teeth which are relatively brownish black in color. But when you scratch the tooth, you're not going to get the catch in it, which means the person doesn't have caries, the person has fluorosis. So a fluoride toothpaste will not cause a patient to have fluorosis, but having a lot of ingestion of fluoride will cause the patient to have fluorosis. I hope that answers your question. You're welcome. Any other questions?
Any other questions do we have? If not, then I would like Dr. Rakesh Gupta to speak a few words for the host.
Yeah.
Sir?
Hello, Dr. Nithya. Am I audible?
Yes, doctor, you are audible.
Yeah, it was a wonderful session and it was a much required session.
Thank you so much.
Yeah, when we are seeing patients in our general practice, what we see is we only, know only few conditions. So here,
Yes.
I would like to tell the participants that sometimes dental signs are telltale sign for some systemic illness and more graver types of diseases like as you had mentioned about submucosal fibrosis. We see it very often. And secondly, identifying the lesions, cancerous lesions is very important because if you pick up at early stage, the reversibility rate or the chances of recovery is also very high. So many a times patients, they avoid going to dentists. They feel, the family physician will take care of everything. But that kind of an understanding is not correct. So we as a physician should encourage whoever approaches us or the patients coming to us to take dental opinions. Many a times they just sit until unless, they feel, ultimately, tooth removal is the only solution. So that is what, there are a lot of misconceptions. We are practicing in urban setup, so we don't find it very, very, very frequently, but I have been exposed to the rural areas of Maharashtra. So there the only final destination is removal of tooth. So you have to understand, and then they feel that, once the tooth is removed, ultimately you can put a denture and that will take care of everything. So these misbeliefs and wrong beliefs are there in amongst us, although we are, in the 21st century, but there are still such prevalent thoughts. So it was overall a wonderful session, and I would like to convey hearty thanks for you to spare a valuable time today for all of us. Thanks a lot.
Thank you so much for giving me this opportunity. I really enjoyed giving this session and I hope it was helpful to everybody.
Yeah. It was a wonderful, and it was a synopsis of, we could at least revise our dental anatomy, which we had forgotten.
Yeah, I think even I got an opportunity to revise it myself.
Yeah, this time it was an applied part.
Yes.
Application was much more helpful.
Yes.
I would like Dr. Sagar Doshi to give a vote of thanks.
Yeah, always. Special props, Dr. Nithya Ramesh. Thank you for this valuable session detailing the clinical aspects of applied dentistry as well as the diseases of the oral cavity with such a beautiful presentation. It sure goes a long way to learn these timeless fundamentals and to also apply them to our clinical practice as Sir just detailed. And always special thanks to Sattva Charitable Sanstha for providing this platform to help nurture budding homeopaths and by guiding them along the direction of their goals. Lastly, thank you to the audience for being such patient listeners and interactive listeners as well. Hope you all enjoyed this session. We'll be having many more such sessions in the near future, so kindly stay tuned and have a wonderful evening. Thank you guys.
Thank you so much.